Welcome, everyone, to the second in our series of Insulin to Innovation events. I'm Krista Lamb, and I'll be your host tonight. We acknowledge the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. As we may have viewers from across Canada and beyond, may we suggest that you research the history of your land using the website and app native-land.ca. So thank you to everyone for joining us tonight. I'm very excited to be here for our second event. We'll be talking about diabetes and homelessness and food insecurity. You can submit your questions in the chat box or via Twitter at RCI Science, or you can email them to information@rciscience.ca. As a reminder, please be respectful and polite in the comment box. The moderators will be monitoring the chat and they'll be taking action as appropriate. I'm so happy to have Dr. David Campbell as my guest tonight to discuss diabetes and homelessness and food insecurity. Dr. Campbell is a physician and health services researcher who focuses on social disparities and how they affect clinical outcomes. I first met David when he gave a talk during his PhD studies, and he blew everyone away with the ambition of his project, and he continues to blow me away with the importance of the work that he does. So welcome to the show.
Thank you, Krista. It's a pleasure to be here. Thanks so much for having me.
It's lovely, and I think this is such an important topic, and I'm so glad that we have the chance to sort of tell people more about this. So let me ask you first, what was it that inspired you to work in the area of diabetes and homelessness?
Yeah, great question. A long history on that one, dating back to the very early days of medical school. When I was a medical student, there were some students who wanted to start up something called a student-run clinic. And this was a model that has been used across the United States and at a few places in Canada. But at the University of Calgary, we just kind of started talking about the idea about starting to have students, medical students, contributing in some way to their community and providing some basic level of care under the supervision of preceptors for underserved populations. And we had the opportunity to work at the Calgary Drop-In Center, which is actually the largest homeless shelter in Canada. And we got a student-run clinic started. So I was actually part of the very first class of people who started that work going. And so that was at the very beginning of my medical training. I had that exposure to seeing the many challenges and barriers that this population faces to getting access to healthcare. And from there I moved on and went into my internal medicine residency and other aspects of my training. But this theme kept cropping up, that at every turn I would see people who experience social vulnerabilities much more frequently than you'd expect to, and they're overrepresented in our emergency departments and on our medical wards, presenting with things that ideally should be treated in the community, and we shouldn't be seeing many people with diabetes in the hospital if they're getting access to good medical care and food and everything that they need that should be managed at home. But I was, struck that time and time again, we were seeing people who experience homelessness and food insecurity and other social vulnerabilities way overrepresented in the acute care settings. And that just led me to want to delve a little bit further to understand this problem and see if there's anything that we could do about it to try to help people be more empowered to manage their diabetes at home and wherever their home may be, and try to keep people safe and well as best as possible and out of our hospitals where nobody wants to be.
Yeah, and I think I remember back to the first time I interviewed you about this, we had talked a little bit about some of the things that sort of when you're looking at it from an academic or research frame of mind, sometimes you have these ideas about what is going to be the issues that people face and what are the things that might be able to help them. But when you actually ask them and talk to them, very different. So what are some of the misperceptions that you had or that you see changing as you work further in this area?
Yeah, that's a really good question. And, absolutely. I think a lot of times as healthcare providers, we think we do so much good, and we do some good, no question about that. But when it comes to a disease like diabetes, which is managed day in, day out by people who live with the condition, right? And they may only see me as a diabetes specialist once or twice a year, maybe once every 3 months at most, and even people's family doctors are involved, but only intermittently, whereas diabetes affects people every day of their lives. And so, I think sometimes I went into this thinking that, well, it was access to healthcare that was a big thing, that people experiencing homelessness have a hard time getting access to specialists like me or family doctors, or, it's the healthcare that's lacking. When you talk to people, that may be a problem, but it's not the greatest problem they face. It's stuff like accessing the medications they're supposed to take every day, and accessing food that they have to think about constantly. And those are the things that are really on the minds of people that have to live this struggle of how do I make ends meet and also do all these things that they're asking me to do with my diabetes. So that was just a learning for me that, we see things very differently if we're on this side of the table, being the healthcare provider, or on the side of the table, somebody living with a complex condition like diabetes and trying to manage all of the social and structural barriers that people face.
Yeah. And when I first thought about this project, and it may be very different, I was like, because you decided you were going to work very directly with people who are housing insecure or homeless. And I was like, I would feel like there were a lot of more important things that I would be worrying about if I was worried about where I was going to live than participating in a research study. However, you found that it was really easy to find people and they were very excited to be involved. So can you tell me a little bit about that?
Yeah, absolutely. So anybody who's done research knows that you never described recruitment as easy. There's always challenges getting people and getting the right people. But I was surprised how quickly we found people, and people that were really engaged. And when I tell people about that work where we work really closely with the community to study things that they're interested in, people say, well, we can't find these people. When people are homeless, they don't have phones, they're hard to contact, you lose touch with them. So how are you going to do a research project where you need to meet with them every week? People aren't going to be able to do that. And I didn't know how it would go. I said, well, maybe you'll be right, but let's try it out and see. And actually what we found is, there was certainly some of that. And of our participants in our group, people are frequently hospitalized for various things. They face all kinds of challenges. They have to move from place to place. They do lose their cell phone from time to time. But people are really committed to the process, and we were really impressed. Like, we had over 80% attendance at our group meetings. So we had 22 meetings over the course of 6 or 7 months, and we almost always had really, really good attendance from people. People felt really committed and bought into the process of participating in research. And I think it's because they saw that what we were doing was a little bit different from what they'd seen before. I think a lot of people in communities and patients kind of have an idea of what research is. And when a researcher wants to study you, they come and they ask you questions and they leave, and you never really hear or see them again. And that's a very different approach from what we did with the participatory research project, where they were really co-researchers with us. They helped us to decide what we were going to study and how were we going to study it. And we met with them so frequently that the decisions really lay with them. And I think that's what really helped people to be engaged in the process and feel like they were contributing to something that was meaningful.
Yeah, I remember I spoke at one point to one of the women who was a participant in the project, and she was talking about how much she was excited about having a voice in that project and being able to share some of her work. And this is the Home Sweet Homeless project that we're going to talk about in a second. But how did you find that most people were really excited that you wanted their opinions and that you wanted to know what they thought about things?
Yeah, absolutely. I think, all of us like to share our learnings, and we like when people want to hear us and want to hear our experience. And I think just giving people a chance to have a voice and to be heard is important. And I think a lot of times people that are in situations of marginalization, or, if you're homeless, your voice, a lot of times it's easy to feel like your voice isn't being heard or doesn't count. And so an opportunity where, I went to the community and I said, I want to hear your experience and I want to do what you want to do, right? I'm not coming here with my own preconceived agenda of what this research group is going to do, but we're going to do what's meaningful to you. And I think that that was really impactful for a lot of people to say, I've got somebody here, a researcher or a doctor who wants to hear what I have to say, and not only wants to hear my story, but wants to do something about it. And I think that's really what's empowering about this kind of research, is when you're able to give people that power that often is held by doctors and researchers and healthcare professionals.
Yeah, and we just saw on the screen the Home Sweet Homeless logo. And I really want to talk about this because usually in academia, and I use this as an example in my presentations all the time, the end goal is a publication in a peer-reviewed journal. And you did that. And it was a great paper, but you didn't just do that. You created the Home Sweet Homeless project, and you really worked with the participants to help come up with something that would tell their story in a really different and unique way. And so I'd love for you to talk about it a little bit.
Yeah, so everything about that project was community based. So that logo, the name of the exhibit, the way we collected the data, that was all driven by the community. So even just the logo here I can talk about is we sat down with the group and we said we want to share your stories and we want to put together an exhibit to show your work and the photos that you've put together, and what should we call it? We should have a name. And the group came up with this idea together of Home Sweet Homeless. And they came up with an idea for the logo, and so really everything about it was driven by the community. Even what this is an exhibit of photographs that were taken by our group members, our co-researchers, and so there were 8 of them. This is one of the photographs, and they, the topic was very broad. It was going to take a picture of diabetes and homelessness and potentially something that has to do with food or how food interacts with all of this. And then we gave them cameras. We had them trained by a professional photographer on how to take photographs and about composition and lighting. And we sent them out in the community and said, hey, take a picture that represents your experience managing this. And they came back with photographs. And then when they came back with their photographs, they chose which ones we would move to the next stage with. And then they made these narratives that really told their stories. And this is a really impactful one by one of our participants named Matt. And this is Matt's story that he shared about how this is not him in the photograph, but how this individual in the photograph, he could see himself represented there. And really, I think it tells a really powerful story of some of the challenges that people who experience homelessness and in the same time have to manage diabetes might face. And so that was kind of the whole point of Home Sweet Homeless, was to give people a platform to share their experiences with the world, like you said, not just with the academic community, but with other people, other real humans. And so we displayed this exhibit at various academic hospitals and teaching centers in Toronto. We even set it up at a mall here in Calgary. We had it displayed for the public to come and view and learn about what people's experiences were like. And we took this exhibit kind of across the country, and it was a great experience. And in most cases, we had one of our group members there to share their experience and speak to what it was like.
Yeah, I was able to chronicle a little bit about your work in my book. And one of the things that I was so impressed by was there was this sort of visceral reaction that you have, because if I had read in your publication that, someone receives this breakfast that is, orange slices and a cookie, that would have been one thing for me to sort of intellectualize that. But for me to actually see the photos of what people have to, they have to choose between whether they're going to eat or whether they're going to eat something that's not great for their health condition. And so for me, this was just such a powerful way to showcase the research. And I'm curious as to what the research community thought, because it is very different from what would normally be the case with presenting an academic project.
Yeah, really good question. And I've been really impressed with my colleagues in the world of academic medicine and how positively this has been received, right? I think the greatest manifestation of that is that, this work ended up getting published in the Canadian Medical Association Journal, which is, our top journal and one of the top 10 medical journals in the world, which, medical journals and the higher tier medical journals really look to publish things like clinical trials and practice-changing research and usually really quantitative things. But the fact that a top tier medical journal was willing to publish this work and disseminate it to the academic community to say this is still valid data and valid research and important learnings for our community to have, even though they're photographs and stories, but we can learn a lot from them. So I think it does represent a bit of a paradigm shift in our world in academic medicine, that we're starting to see that there are many different forms of evidence and data, and one form isn't necessarily always superior to the other. And really getting people's stories is a really valuable and impactful data collection method.
Yeah, and as the slides were going by, there is the, I don't know if Celia can bring back the pizza pop one, but that really just hit me. And I mentioned this in my book about the idea that, if you have to choose between buying a bag of salad, which will keep you, you can eat that and be hungry a few hours later, or getting, a $2 package of 4 pizza pops. It's really, really like hard to not understand why people make the decisions that they do. And so what did you think in terms of what people told you about food and how they're trying to manage their condition and the barriers that they face?
Yeah, absolutely. It's a really good question. And we heard food was actually, we did an exercise with our group where they kind of prioritized all the different barriers that they faced. And we asked those questions. We came up with a list of different types of barriers that people might face in this setting. And there were 43 different barriers. And we had them rank them or rate them on how impactful it was on their diabetes. And we had clients or people with lived experience do this, and we also had providers do the same ranking exercise. And we found a really interesting finding that by far, for among the people with lived experience, the food was the most striking feature. It was the greatest impact, most impactful barrier by a long shot. And when we asked the providers, food and access to food fell much lower on that list. And they thought about things like themselves, like healthcare provider access and mental illness, and all those things that providers thought were more impactful. But from the lived experience perspective, food was the main driver. And like I said earlier, I think that's really because each of us has to make those decisions about food every day, right? When we go to the grocery store, we need to decide what to buy. We need to balance that with how much money is in our bank account. And then every day we need to think about, what am I going to eat, right? You wake up and you're hungry, you got to find something. And the unfortunate reality is 4 or 5 hours later, you're hungry and you got to eat again. So food is just something that's ever present. And especially if you're somebody who lives with diabetes and you see the impact of your food choices on your blood sugars, and you can see what it does. But despite that, if you're somebody who lives not only with diabetes, but also the constraints of a really limited budget, it's just a constant struggle. And you're trying to decide, like you said, Krista, like, what do I do here? I need to eat, but I know that if I eat the food I can afford, it's going to wreak havoc on my numbers. And so it's just this constant struggle that people face. And it's not just when people are homeless. What we heard is that when people are experiencing homelessness, it's a real struggle because they're eating food that's provided to them in shelters and in community kitchens, which might be low in nutritional value. But then once people get housed, right, and homelessness for most people is transient, and people move in with family, or they get their own place, or they end up in supportive housing, which is what we want. But now you've got to make your own food, and maybe you've been homeless for a little while. And so that's what this photo here is talking about, is just about how this person's kitchen was just such a godsend for him. And he just talked about being able to make his own meals and have a place to cook was just such a privilege, was really impactful. But by the same token, this is actually the same person who did the pizza pops. So having a kitchen is great, but if you can't afford the kinds of food that you want to be able to cook in your kitchen, then you're left eating pizza pops, because like you said, it's a lot cheaper. So food is just ever present, and it's not just people who are experiencing homelessness, but food insecurity is actually quite a pervasive problem in our society in Canada. Food's expensive, and especially healthy foods, right? The kinds of foods that people like me, diabetes doctors, tell people to eat are often more expensive than the cheap junk foods, and they're not quite as filling. So it's a major problem.
Yeah, and that's a really good transition into your new projects, because I know that the research that you're currently doing really looks at food insecurity and how challenging it can be for someone with a chronic illness like type 2 diabetes, who really needs to consider what they have to eat and the barriers that they face to being able to afford healthy food. So can you tell us a little bit about that?
Yeah, absolutely. So, research, the kind of research I do generally follows a trajectory that first we have to document a problem and understand what that problem is. And ultimately, what we want to do in kind of the health services and policy research world is move towards some kind of a solution or an intervention that addresses the problem. And so for years, people have been documenting the problem of food insecurity on diabetes and other health outcomes. So I think we have a pretty good sense of that by this point. What me and my team wanted to do was come up with an intervention that could address that problem, the barrier of food insecurity in the context of diabetes. And so what we're doing is providing a food subsidy that helps people to access healthy food. So you can access healthy food at a cheaper price, essentially. So we're giving people free money that can only be spent on healthy foods. And in order to incentivize people to buy those healthy foods and to make it more affordable, that and ultimately what we want to show is that if we address that food, the barrier to food insecurity, which is cost, if we take care of the cost, take that out of the equation, people will purchase healthier food and will make the right choice. And do the things their doctors are asking them to, really trying to get at the point that the greatest barrier to people's adherence or following their doctor's advice isn't necessarily that they're making bad choices or they're not doing the right thing, but it's that they can't, that their agency is constrained, that they don't have the same luxury of making choice that many of us do. And so if we give them that choice, then we can improve their blood sugars and ultimately improve their health outcomes. And our hope ultimately is that we can show people like government agencies and funders that if you give people access to the upstream things they need to manage their diabetes, whether that's medications or food, that will actually save money by keeping people out of hospital, helping them to manage their diabetes at home and not have the debilitating complications that we know come with diabetes if it's left unmanaged for a long period.
Yeah, and whenever we talk about this, I get so excited because I feel like there's this misconception that so many people have that type 2 diabetes is something that we can control with diet and exercise. And so often we completely forget the many, many, many factors that go in and make it such a complex condition, including that diet and exercise are not things that are accessible easily to everyone. So really, really excited that you are moving into that area. And so I'm going to give the audience a little bit of time now to put their questions in the chat box. We will take some questions at the end from the audience. So please do put a question into the box if you're thinking of anything. And in the meantime, we're going to play some questionable news. And because this is very food-based, I suspect these will be food-based questions. And for those of you who attend RCI Science events regularly, you'll be familiar with this. And I hope that you will play along and post your comments in the comment box, because I'm going to show Dr. Campbell 3 headlines, and he'll need to guess if that headline is fake or real. And this is a great way to test our media literacy. So let's do this. All right. Eat pomegranate every day to prevent diabetes, arthritis, heart disease. Is that a real headline that ran in the news or a fake headline? And we're not questioning the science, just whether or not it actually ran in the news.
Yeah, thank you for clarifying. I would guess, this has a grabby nature to it. I think probably people would be drawn to something like this. So even though I question the scientific veracity, I'm going to say this probably did run in the news, Krista.
It did. So unfortunately, the author of the piece did not explain the research that led them to make the supposition that pomegranate could do all of these things, including lower blood sugar. Again, pomegranate is a fruit, so you might want to eat it as part of your healthy diet, but I think we may question whether or not some of these claims are verifiable. All right, so the next headline, diabetes diet. Why drinking 8PT every day can lower your blood sugar levels. Is it a real headline or is it a fake?
I don't even know what 8PT is, Krista, but I'm gonna say maybe this one. I could see this as well. I see these headlines all the time on various social media outlets. I could see this probably running as well. So I would say this probably did run somewhere as well.
All right, so let's see. Yes, it did. I will say that when you read this article, it does talk about how if you replace sugar-sweetened beverages with like an herbal tea, that can be helpful. And I think Diabetes Canada would agree with that, because we know that sugar-sweetened beverages are a major issue for people who are at risk for type 2 diabetes. So something, it's questionable, but there's maybe a little bit that, we could always drink more water. So
I think you're right, Krista. The problem with a headline like this is that it makes you think that it's directly attributable to the tea, that there's something medicinal in the tea that is preventing or lowering blood sugars. But you're right, it probably has nothing to do with the tea, and it's more about the fact that it's substituting out for other things that we know would raise the sugars. So yeah. It's probably yes.
But questionable. All right, so let's see the third and last headline. A pumpkin spice a day keeps diabetes at bay. Why you should be eating pumpkins and cinnamon for your diabetes. Is it a fake headline or is it real?
I'm going to go with fake for this one.
Good call. Although, and it is really interesting to see this because it is based on a lot of real articles that, and I mean, I think for anyone who works in the diabetes field, if you haven't heard that cinnamon will cure your diabetes, then you haven't been working in diabetes long enough. For those listening, it will not, but it is a common thing that will pop up, especially online. And I'm sure pumpkin is a great food, but it is not necessarily going to do much for your diabetes risk, unless you've heard something I haven't, David.
Nope, no, I would agree with you, Krista.
All right. So let's take a few questions from the audience. And so let's talk a little bit about this. This is a great question. Do you think you will find a creative way to present your findings around food insecurity?
Yeah, that's a good question. So that study is a more traditional clinical trial. So we are actually, in order to have the most impact on the scientific community and on policymakers, what we're really trying to do is show in an evidence-based way that giving this food subsidy results in improved blood sugar. So we have to follow a more traditional methodology for that study. So we are doing a randomized controlled trial. So ultimately, we will end up with the usual research paper stuff. There will be a relative risk reduction or a decrease in blood sugar levels for the intervention group versus the control group, and that'll get published and disseminated in the scientific community. But at the same time, we are doing something called integrated knowledge translation in that project. And that's really where we've started working with the policymakers locally here in Alberta, our insurance providers and our government agencies and our health system to really identify this problem from the beginning. And so the hope is by working with the end users of a research product from the very beginning, that you end up with a research product that addresses their needs and helps them to make policy decisions. So certainly we'll be working with them. We will find ways to present where, there are other projects that will happen from this. So there will be some qualitative research. We have some students working on qualitative projects, interviewing those who received the subsidy to talk about what their experience was like. So there will be narrative elements that will come out of that. We so far haven't planned for an arts-based approach, like a photograph, like a photo voice type approach, but you never know what comes next. So to answer your question, I think the main output will be a traditional scientific output where we can send it back to the funders and to the government agencies and say, if you invest in this program, these are the outcomes you can expect, and it'll lower blood sugars by this much, and it might save us this much money. But we do think it's important to disseminate research findings more broadly to the public, as well as to other stakeholders who aren't as interested in something like a standardized difference or a relative risk reduction, but are more interested in people's stories. So there will be stories and qualitative research involved in that project as well.
Wonderful. And the last question, because we're almost out of time flies. What did the people who were involved in the project think about the end result? Were they happy with it?
Yeah, excellent question. That was something that we built into that project, is we had an evaluation plan to really ask people at the end, what did they think about the whole experience? Was it worth their time, right? That's what we were really worried about, is we took up a lot of people's time. They gave us their time, and they came and shared their experiences every week. They came and spent several hours with us. And so we wanted to know, was it a worthwhile endeavor for them? And so we did some surveys as well as interviews with people at the end. And what we did is we actually had some of our colleagues, not me and my research associate who did the group, but we had a colleague who didn't know the group go and do these focus groups and interviews with them, so they would feel more at ease and less biased to feel like they had to tell me nice things. And so they were totally free to say what they thought of the process, and it was anonymized, so we didn't really know who was giving the feedback, but we received overwhelmingly positive feedback that people loved the experience. They loved having their voice heard. They liked, it wasn't universally positive. There were some things that they, suggested we do differently next time, and that's what we're doing. So we're actually convening a very similar group to what we had in Toronto here in Calgary. So we actually have a group that just started. We're actually meeting virtually because of COVID. And so we've taken our learnings from the previous group and applying that to try to make it a better experience this time around, because I think it's something we can always do better. It was my first time doing this type of research, and it was great to have their feedback to say it was a great experience, but here are a few things that we could do better next time.
Amazing. Well, thank you so much for joining us tonight. This is a topic that is very near to my heart, and I'm so glad that we had the chance to discuss it together. So thank you.
Thank you.
So I hope you all enjoyed tonight's event. Please share your feedback with us and let us know what you think and what you'd like to see in the future. And if you can, please consider supporting RCI Science's free programming. You can visit rcascience.ca/donate for more information. We continue to celebrate the 100th anniversary of the discovery of insulin and Diabetes Awareness Month with the next in our series of short conversations, Work It Out with Dr. Desi Zaharieva, which will be on diabetes and exercise, and that will take place on November 24th at 7:30 p.m. Eastern Time. And you can follow along on Instagram as Stephanie Karalik from the Dream Diabetes Research Team in Manitoba will take over RCI Science's Instagram account on November 16th. You can also see the details of all of the upcoming events on RCI Science and the Insulin to Innovation websites. For early updates on what's next, subscribe to RCI Science's newsletter. And thank you to everyone who joined us tonight. We look forward to seeing you at the next event very soon.